Well, ladies and gentlemen, this is what we have available for treatment. And if we should sum up what we think these drugs are doing, and I think it's reasonable that we discuss the detailed mechanism of the drugs we have before we discuss the mechanisms of future drugs. So antimuscarinics, of course, they block muscarinic receptors. They are efficacious, as we all know, and they are still the first line of therapy. So we should know a lot about antimuscarinics and its mechanisms of action. Beta-3 agonist, we have mirror background and maybe by background coming. We know that they relax the bladder. They are efficacious with less side effects than the antimuscarinics, and they are also the first line therapy. Then we have the phosphodiesterase inhibitors, and it was interesting because there was only a few hours ago a symposium on the mechanism of action of phosphodiesterase inhibitors, and also how they could be used and useful. We know that tadalafil improve male LUTs, and that so does other PD5 inhibitors, but we don't know by what mechanism, and we don't really know how they work and if they work in women. And then we have Botox, inhibits transmittal release from nerves, and also from the urothelium. This is a second line of therapy. So let us return to the antimuscarinics. Where in the bladder do these agents actually work? We have all five subtypes defined in the bladder, and we have a majority actually of M2 receptors, but we think that the M3 receptors are the most important for contraction of the detrusor muscle. And we have also muscarinic receptors on the nerve endings, which has attracted some interest because we have both facilitatory and inhibitory muscarinic receptors on the nerve endings, which may be or may not be important. But on the other hand, we have muscarinic receptors on the suburothelium, on the urothelium, in the nerve bundles, in the dorsal root ganglia, and actually we also have it in the interstitial cells. So whatever structure you can discuss in the bladder, we find muscarinic receptors there. But what is then the mechanism? Which receptor type in all these structures are the most important for the effect that we see clinically? Well, one thing that we can agree on is that antimuscarinics decrease afferent activity. And by what mechanism in the different structures? Is it a urothelial effect? Is it an effect on the nerves directly? Is it an effect on interstitial cells, on release of acetylcholine? Actually, we do not know. So we can summarize it that we have a therapeutic window for OAB because we can have effects on with antimuscarinics on OAB without affecting the detrusor contraction. If you take out detrusor muscle, you can, of course, see a very nice contraction with high concentration of acetylcholine. And you block that with the highest concentrations of antimuscarinics. We know that if you give a high dose of antimuscarinics to any healthy individual, they can't pee. But that is not interesting because the therapeutic effect is most probably the effect on the afferent signaling from the bladder. And the absolute details here and what structures contribute, we do not know. So then let us look at the beta adrenoceptors. We have beta adrenoceptors in the urothelium, afferent nerves, interstitial cells, the detrusor muscle, like we had with the antimuscarinics. And what do? We have still more targets being recently elucidated. We have the microvasculature, and we have also the parasympathetic nerves. So we have beta-3 receptors everywhere in the bladder wall. Here, just to illustrate the most common sites that we have discussed from a mechanism of action point of view, and that is the urothelium and the detrusor. We should remember, if we are looking at the detrusor contractions, that we have two types of detrusor contractions. We have the spontaneous contractions, and they don't require input from the spinal cord. I mean, there is a myogenic activity that can be enhanced by local factors, and these generate some tone in the bladder wall. And these, the tone is not coordinated because the muscle consists of units, and these units are isolated from each other. The only way to get a complete coordinated contraction of the detrusor is when there is a release of acetylcholine from the spinal cord, because the nerves can then coordinate all those small spontaneous contractions. But they are important. They generate a bladder tone during filling, and they are each sending some afferent impulses, which we can call afferent noise. But the voiding contraction, that requires nervous input from the spinal cord. There is a massive release of acetylcholine, and that leads to the emptying contraction. So beta-3 agonists, no question, decreases the spontaneous activity. This is from an old study showing the effect on the spontaneous activity in a piece of human bladder tissue. And that has been reproduced again and again. But we also, like for antimuscarinics, believe that even if we have effect on all the structures in the bladder wall, the end result will be the same as for antimuscarinics. We get a decrease of the afferent activity from the bladder. But the detailed mechanism, this is not a direct effect on the detrusor muscle contraction, because that wouldn't have been very useful. Because inhibition of the spontaneous activity, that is leading to an increase of bladder compliance. We decrease bladder tone by inhibiting these spontaneous contractions. And then we need more distension to activate the micturition reflex, to actually start the afferent activity. And that also means that since the afferent activity are producing the sensation of urgency, we have effect on symptoms by these particular mechanisms. On the other hand, we don't have very much effect on the detrusor muscle. So that would be leading to a decreased risk of urinary retention. If we want to look at the molecular mechanism of action, we know that you can stimulate the increase in cyclic AMP, which we know leads to a relaxation of all types of smooth muscle. And we have also another mechanism, activation of potassium channels, that leads to hypopolarization. That is on the smooth muscle itself, but we are not convinced that this is the most relevant mechanism of action for beta-3 agonists. So still, like for antimuscarinics, we don't know the exact mechanism more than we can reduce afferent activity and by that reduce symptoms. As I said, there was an interesting discussion about phosphodiesterases in the human bladder and what they are doing. And the focus was on PDE5 and PDE5 inhibitors. And if you inhibit a PDE, like we see here, this one, you get an increase in cyclic GMP, stimulation of this particular enzyme, and then you can get interesting effects that leads to, well, finally an effect on LUTs. But if we look at it really again, the only thing that we can demonstrate clearly is that you get a modulation and a reduction of afferent activity. So even if there are many other things, still, for example, increasing pelvic organ blood flow, reduction of inflammation, and upregulation of this PKG activity, which we showed before, we do not know. But here you see there is a common theme. Modulation and reduction of afferent activity seems to be the thing that makes all our drugs work. And this is, well, a conclusion made in a review that PDE5 inhibitors are safe and effective improving LUTs. Of course, it also improves erectile function, which is nothing negative in men with both LUTs and BPAE, benign prostatic enlargement. But we know very little about how if they can be preventive, can they reduce disease progression, and what are really the long-term outcome of phosphodiesterase inhibitors in male LUTs. Finally, Botox, the mechanism of action there, we think that this is something that we actually know anything about on the real detailed level. We know that we need attachment proteins for having a release of neurotransmitters. And these attachment proteins, which you can see some of them here, are affected by Botox because they cleaves one of these proteins, the SNAP25, and the whole complex that is necessary for transmitter release will be ineffective. And that decreases both afferent activity and the trusocontraction, and I have tried to illustrate it here. There is no Botox release, stops the release of acetylcholine. When you have the voiding contraction and the release of acetylcholine, you get a decrease of that with botulinum toxin. So there is no question that if you give enough botulinum toxin, you can paralyze the bladder completely. But that is not how it works in OAB. It actually works by inhibiting afferent function and the release of afferent transmitters. Here illustrated from the urothelium, but also from afferent nerves, you can inhibit the signaling. So even here, the main theme also for the Botox is that you decrease afferent activity. But that is not all. And we don't really know how the different components in the mechanism of action of Botox actually are, because we inhibit the release of acetylcholine, ATP, substance P, and also that we affect the expression of receptors. And then people claim that there is a central effect in the Botox mechanism of action. And well, we haven't really dissected out which component is the most important. But again, we think that decrease of afferent signaling from the bladder is the main mechanism of action. So Are we now at a position actually to discuss those drugs that are the continence drugs for the future? A mechanism that is much in focus just now is ATP and P2X3 receptors, and we have receptor antagonists. These drugs have not reached the clinic, nor has any of those TRPV1, 4, TRPA1, and so on, the TRP channel antagonists. We know that they block TRP receptors, but for each of them, we don't actually know how they affect the mechanism, but most probably also here, if they are effective in OAB, a main theme will be inhibition of afferent activity. Another site of action that we don't know very much about is, of course, the CNS active drugs. We have a lot of CNS active drugs that actually work, but they all are associated with side effects, so we are not using them. We know that they can have selective effect on one type of receptor, but we are not sure that this is the real mechanism of action and where exactly in the brain they work. So this field, and to actually elucidate how our drugs that we use for OAB treatment, how they work, is still open for further investigations. And to state that we know that what these drugs do is just to deceive ourselves. Thank you very much for your attention.